Hello everyone, welcome. I'm Dr. Shariful Halim and today I'm going to talk about sensitivity and specificity. So here, before going to further discussion of sensitivity and specificity, let's first talk about what is true positive, false positive, true negative and false negative. So whenever we test someone, a patient who might have the disease or might not have the disease, so we have two distinct patient population, healthy and diseased, and when we test him we can get two kind of result. The test can either be positive or be negative. So actually there are four distinct variables here. So suppose we test someone who truly have the disease and the test becomes positive. So those are test positive and truly have the disease. Though they are called true positives. So they are positive in testing and the truth is right because the patient truly have the disease. Next is the test can come as positive but the patient might not have the disease. So the patient don't have the disease but still the patient have a positive test. So those are called false positive. The test is positive but this is false because the patient does not have the disease. Another case, the patient may not have the disease and the test may come negative. So the test is negative and the patient also doesn't have the disease or don't have the disease. So those are called true negatives because this negative test is actually valid or true because the patient does not have the disease. Another situation is the test might turn out to be negative but the patient actually may have the disease. So the test is negative but the patient actually have the disease. So the test give you a negative result but still the patient have the disease. So those negatives are false negatives because the patient really have the disease. So this is the basic idea about true positive, false positive, true negative and false negative. So the positivity or negativity based on the test result and the truthfulness or falsity based on the patient condition. Okay, so that's the basic idea here. So let's first talk about the perspective of sensitivity. Suppose a patient comes to you and has some symptoms and signs suggestive of SLE, like the patient has pallor, patient has the butterfly rash, joint pain, fatigue and discoid rash. So symptoms suggestive of SLE. Now what test should you do first? And the property that you are looking for in someone to test for SLE is high sensitivity. And I will talk about what is sensitivity later. I'm just trying to get you an idea of what is sensitivity. So high sensitivity test is needed for this patient. And the test we do actually in reality is ANA or anti-nuclear antibody because this is a high sensitive test. Question: which ANA testing result is most valuable here? Which is valuable? Is that a positive ANA test result or is that when ANA becomes negative? So the answer should be when it is negative. It has more value. The ANA testing is more valuable in this situation because if ANA is negative, you do not need any further testing and you are confident that this patient does not really have SLE because this ANA has a high sensitivity. High sensitivity means this ANA testing should identify most or maximum of the people that have SLE. So as this ANA testing has came out being negative, this patient most likely does not have SLE. So a rule, very important rule, is SN out or SNOUT. So it means highly sensitive test when negative. So SN and N rules out disease. So this is a very basic concept and rule that you must remember always when solving a question regarding sensitivity. So here sensitivity is also called true positive rate. So sensitivity is actually very important to understand, and sensitivity is always used in people with disease. So very important, with disease. So proportion of all people with disease who test positive, and is calculated by using only people who are in fact ill. And the two variables that we use when calculating sensitivity are true positive. So true positive meaning the patient testing comes out as being positive and the patient truly have the disease. And also false negative, when the test is negative but the patient truly have the disease. So we calculate sensitivity by regarding people or calculating people who truly have the disease but may or may not test positive. So they are included in sensitivity. And high sensitivity cases should identify most or all possible cases like that of ANA. And if high sensitivity test is negative, this makes us confident that this patient does not have this disease. And it is most useful when identifying an ill person as healthy can lead to severe complications or consequences like cancer, which can metastasize if not identified early. So the calculation of sensitivity goes like that. So the people who test positive and truly have the disease, true positive, by the patient who truly are diseased, which are true positive and false negatives. So those are patient with illness, and this is patient with illness who comes out as being positive. Okay, so sensitivity is the true positive rate, or sensitivity is the index of proficiency of a test to identify the people with disease who are actually diseased. So we can actually write true positive and false negative, they all actually included in all positives. So 100% of positives are included in true positives and false negatives. Suppose you have 100 patients, 80 patient came out as true positive and 20% came out false negative. So 100% of the patients are included when we actually accumulate or when we actually add up the true positive and false negative. So true positive plus false negative should be 1 or 100%. So true positive rate plus false positive rate should be 1, and then true positive rate should be 1 minus false positive rate. As true positive rate is also called sensitivity, so sensitivity should be 1 minus false negative rate. So this is a useful formula. We can use it in calculations in certain problems. And if sensitivity is 100%, then true positive divided by true positive plus false negative will be 1. And in this situation, the false negative must be 0 to this for this equation, because if false negative is not 0, more than 0, the result will be less than 1. Okay, suppose this is true positive is 100 and true positive 100, true positive 100, and false negative is suppose 20. So the results will be like 100 by 120. So it will be less than 1. So anything, any time when false negative is not 0, the sensitivity will not be 100%. So for sensitivity to be 100%, false negative must be 0, and all negatives must be true negatives. So here is a very important concept, take home message. High sensitive test or highly sensitive test is used for screening in diseases, like we use ANA for screening for people with ASLE. So ANA for ASLE is a screening test. So those are used as screening test, and especially this is low prevalence. So here we have a case to practice. Suppose mammography has a sensitivity of 90% and a specificity of 98%, and that consecutive tests are independent. And what the probability that women with breast cancer will have a negative yearly screening mammogram for 2 consecutive years. So there are multiple options here. You can pause and press the pause button, and you can solve yourself. And I'm just going right after the solution. You can solve it by yourself and then check with my solution. So here is my solution. So the first thing that we have to look at, this patient have disease. So the patient is with breast cancer. So we have to work with sensitivity, because sensitivity is the statistical analysis of the patients who have disease. So as the patient have disease, we are working with sensitivity. and in this case sensitivity turns out to be 90%. So the sensitivity is 90%. So the test identifies 90% of cases who actually have the disease. So who have the disease? The diseased are true positives and false negatives. Those are the people who have the disease. And if the test can identify only 90% of cases, what percentage does it miss? It misses about 10% of the cases. So it misses 10% of the cases who also have the disease, like the women in this case. So what the question asks is that what is the chance of missing the breast cancer diagnosis in this patient for 2 consecutive years? So let's first calculate the probability of having a negative test when the patient truly does have the disease in 1 year, and then we calculate the probability for 2 years. So probability of having a negative test result in people who actually have the disease is 10%. From that we get this point, or this 10% can be converted to 10 by 100 or 1 by 10. So this is the probability of having a negative test result when you actually have the disease is 1 by 10. And if we want to see the probability for 2 consecutive years, we actually have to calculate it by so probability of 2 negative test result in 2 separate occasions is 1 by 10 times 1 by 10, because those 2 are independent events. So we have to multiply them together, which will become 1 by 100. So the answer should be 1 by 100. So this is a very good question for you to have a basic idea and basic practice what is sensitivity is all about. So let's move on to next situation. So specificity. Suppose the same patient with symptoms suggestive of SLE have positive ANA. So as the patient has positive ANA, what test do you do now? So what we need now, we need to validate the positive ANA result, for which we need a very high specific test, and we actually have one, which is anti-dsDNA. And now the question is, when the result of anti-dsDNA is more valuable? Is it when it becomes positive, or is it when it becomes negative? The answer is anti-dsDNA test is most valuable when it is positive, because when it is positive we can be very confident that this patient actually have the disease. So the rule comes. So the rule about specificity is SPIN, SP pin, SPIN. So for sensitivity we have the snout, and for specificity we have the SPIN. So SPIN tells you highly specific test when positive rules in disease, like this patient. So here anti-dsDNA highly specific test, and when it becomes positive it will rule in the SLE. What if negative? If a highly specific test become negative, it doesn't actually mean much. Now our confidence level on ANA positivity should drop, but it doesn't become 0. The patient still might have the disease, but we are not sure now. So what is specificity? Specificity is also called a true negative rate. So here we actually try to calculate the specificity with the people who actually does not have the disease. So what is specificity? Specificity is the proportion of all people without disease who test negative. So the contrast should be made here. So we work with people with disease in sensitivity. We work with people without disease in specificity. So in specificity we are actually working with healthy people. We are actually calculating the specificity by using the numbers we get from healthy people. So proportion of all people without disease or healthy people who test negative, or the probability that a test indicates no disease when disease is actually absent, when the people are actually healthy. So in another way, specificity is a probability of a negative test among patients without disease. So what is the chance that a person that who do not have the disease, and now he tests for the disease and comes out as negative? So test should be negative, Now, what is the probability of getting a negative test result in people without the disease? That's specificity. And value approaching 100% is desirable for ruling in disease and indicates a low false positive rate, because we don't want to tag a person as positive when he or she does not have the disease. Those are called false positives. And a very important note to make, highly specific tests are actually used for confirmation after a positive screening test. Like we use anti-dsDNA for confirmation after having a positive ANA testing. So here we have some calculations. So as I have already mentioned, we actually calculate the specificity by using the numbers from healthy people. So the truly healthy people who test negative and are negative are called true negatives. So it is on top, and we divide it by the people by also true negatives and also false positive. So false positive are the people who comes out or test positive but actually truly does not have the disease. So those are called false positive. So you can look at that all of those people does not have the disease, and we actually calculate the specificity by using their numbers. So again, 100% of the people should be included in true negative rate plus false positive rate. So this comes out as 1 minus specificity as equals to false positive rate. So specificity is equals to 1 minus false positive rate. So this is sometimes useful when we calculate in some specific questions or problems. And if specificity is 100%, the false positives should be 0, because all positives must be true positives to have this equation to be 1 or 100%. And a test with a high specificity has a low type 1 error rate. You might want to note that down. I will discuss it about later. And specific tests are most useful when identifying a healthy person as ill can lead to dangerous, painful, or unnecessary treatment. So we use sensitivity to identify ill people. We use specificity to identify the people who are actually healthy. So how we actually standardize a diagnostic test? Here is an important graph which is very valuable to know about. So here in this graph, in the x-axis, you have the number of people that you are testing, and here you have the cutoff values for a test. So suppose we are doing an ANA testing for people. So the level of ANA that we set for diagnosing someone can be set high, like here, or can be set as low as here. And the basic idea here is, if we set a cutoff point in a higher value, that we will be able to identify less people, and if we set a cutoff point in a much lower value, we will be able to identify many people as positives. So let's get an idea. So here in this graph, that you can see that this blue graph represents the patient without disease. So the range for ANA in patients without disease can range from this lower value to values as high as in point C. And the red curve is for the people that have SLE, and they can have values as low as A up to as high as this ultimate point. So those are the people without disease, and those are the people with disease. And we can set the cutoff point of diagnosing SLE by using ANA in different parts of these curves. So we can set the cutoff point in A. So whenever we set the cutoff point in A, what does it mean, or what does it signify? If we set the cutoff point at A, we see that all the positive people, all the people with disease can be now identified, because the people have a value more than A. So we'll be able to identify all the people with the disease. But here comes a problem, because as you can see, this point actually also cuts through the people without the disease. So many of the people who actually does not have the disease will have values more than that. So those values will be positive value, but though they will be false positives. So in case of setting a lower cutoff value, we'll have a lot of true positives, and but also we'll have a lot of false positives. So the false positives are depicted by this part of the graph. So those are false positives. And actually what it will affect, it will affect mainly the positive predictive value. It will result in a decreased positive predictive value. And if we set the cutoff point in the middle, what do we have now? If we set the cutoff point here, now the people without disease will be marked as having no disease in more cases. But now we have a problem. Now some of the people who have the disease actually will test negative, because many people who have the disease actually have a value much lower than this set point B. So it also becomes a problem. And when we set the cutoff value in C, which is a much higher value, now the advantage here is we actually do not identify any people without disease as being having negative. So that's a positive thing. But the negative thing in case of C is many people with the disease will also test negative, because they have a much lower value than C. So possible cutoff values should tell us. So A should be 100% sensitivity cutoff value, because 100% sensitivity means we can identify all the people with disease. And C is a value for 100% specificity cutoff value. Why 100% specificity cutoff value? Because in C we can identify all the people without disease. We can identify all the healthy people. So for A we can identify all the people with disease. For C we can identify all the people who are healthy. But each of those have a problem associated with, because we miss a lot of people. In case of C, we miss a lot of people with disease. In case of A, we actually include a lot of people as being having diseased who actually don't have the disease. So we have to do a practical compromisation between specificity and sensitivity, making a cutoff value in between A and C. So this concept is very valuable. And here I have shown you another better look into this. So here this normal line, straight line, is the negative people, the people who actually do not have the disease, and this dashed line is the marking for people who have disease. So those are healthy line, this is healthy line, and this is disease line. And suppose we are testing someone using this cutoff value. So this line is the cutoff value. So as you can see here, so below this cutoff value, the test will tell everyone is negative below when they have a value lower than that, and everyone in this area will have a positive test result. So those will be negative test results, or those will be the people who will test negative, and they will be the people who test positive. So here comes an idea. So whenever the people who are healthy test negative, they will be called true negatives, and the part of this graph actually crosses the cutoff value. So that's why this portion, the patient truly does not have the disease, but they test positive. So that's why we are called them false positive. And in this curve, the people actually are diseased, and when they are diseased and they test positive, they are called true positive. And when they are diseased but this portion of the graph actually lies below the cutoff value, so that's why they will test negative, but in truly they have the disease. So that's why we are calling them false negatives. So this is a basic idea. This graph will be useful later when you solve the question. So here is a question for you. I brought it from eWorld to get you an idea what we are talking about, and we use the concept that we have already learned. So a serum biomarker level is being used for early detection of pancreatic carcinoma. Test results in 200 healthy volunteers and 190 patients with biopsy-proven pancreatic cancer are given below in the figure. So those are the people who test negative, and those are the people who test positive. And this line this line is the line for healthy people, and this line is the line for dash line for people with the disease. So setting the cutoff value of the serum biomarker level at point X instead of point Y would most likely result in what? So when we set the cutoff value from here to here, what are the changes that we expect? So let's try to find out what kind of change we can expect. So first of all, they try to tell you lower sensitivity. No, the sensitivity will be higher, because whenever we set a low cutoff value, it will be able to identify more people. So this is not right. Lower number of true positives, that's also be false, because when we set the cutoff value from here to here, the number of people with positive test result now will increase, because you see that this graph will lie to the right of the cutoff value, so the positive test results will be increased. So true positives will be increased. So the lower number of true positives is false, because the true positives will be increased. And next, lower number of false positives. So how about that? And false positives are actually people who do not have the disease but test positives. But in this case, when the cutoff value was here in Y, the number of false positives was like that, because they test positive but they do not have the disease. But when we set the cutoff value from here to here, the number of false positives now becomes this line. So I'm taking another color. So this is the part where what tells you the false positives, because they are false positive because they do not have the disease but they test positive because this lower cutoff value. So first this false positive part was just this one, and now it's greater, so that's why the false positive rate should increase. So lower number of false positives is false, it's not true. And next one is a bit tricky, lower positive predictive value. So let's just think about that. So what is positive predictive value? Positive predictive value is true positive by true positive plus false positive. So when we set the cutoff value from a higher value to a lower value, what happens to those numbers? So true positives, so those are the true positives. So power of true positive increases, so true positive value increases here, and false positives also increases, so this is this part, and the relative increase will be more in favor of false positives, because false positive is in the lower part of this equation. So this will lead to a lower number, and the positive predictive value will be decreased in this specific situation, and higher numbers of false negatives will be actually not true. This is false, because false negatives are the people who test negative, so who test negative but are not negative. So those peoples are just this line. So those are people with the disease but they test negative. Now their value actually decreases, because this just represented by this tiny portion of this graph, so their value is actually decreasing in this situation. So the answer should be lower positive predictive value, and that's a very important question. You have to practice it for multiple times to get a better idea. So here answer is low positive predictive value, because there is increased true positives as we have a decreased cutoff value, and also increased false positive, and PPV means true positive by true positive plus false positive, so there will be a decreased number of PPV, so decreased positive predictive value, so low PPV should be the answer in this case. Another problem solving which is a bit easier than the previous problem is a diagnostic test has a sensitivity of 64%, which is a bit low, and the specificity of 99%, which is high. And now question is, such a test would carry the risk of which kind of problem? So what kind of problem we are expecting in this specific case? Is it a high relative risk? No, because relative risk we cannot calculate from this information. Is it a low likelihood ratio? No. Is it a false negatives? or is it a false positive, or is it a low power? So I think as this equation is about sensitivity and specificity, we might want to work with false negatives and false positive. So basic idea. So here we can think about that. Whenever a test has a low sensitivity, sensitivity is true positive by true positive plus false negatives. So as this test has a low sensitivity, we are working with true positives and false negatives. So the test will carry a risk of having a very high number of false negatives, because whenever a test have a very high number of false negatives, the sensitivity will drop, because the relationship between the false negatives and sensitivity is inverse. So a low sensitive test will have a problem with false negatives. It will have a lot of false negatives. So the solution is, again, I have put it here. Highly sensitive test picks up almost all the positive tests. If you do not pick all the positives and tag them as being negative, wouldn't there be false negatives? Absolutely. So a test with low sensitivity is kind of a liar. They lie about true positives and gives you lots and lots of false negatives, because they cannot identify them as being true. So that's all from me today about sensitivity and specificity. I hope you are benefited by this lecture. What you need to do, you need to solve as many questions or as many problems as you can, because the more problems you solve, the clearer the idea gets in your mind. And also, those are sometimes confusing. That's why you have to review these items for multiple times. Thanks for watching my video.